Good evening, good afternoon, good morning, or good night, whatever time it is, wherever you are. I'm Dr. Brian Novi, and welcome to Can Your Preparation Stop a Coccus here with Viva Learning. Before I get started, I need to disclose to you that tonight's presentation is sponsored. GC America is providing an honorarium for tonight's lecture, and you'll understand why, because I'm a huge fan of their products, and I'm going to be showing you some of the ways that I've been using them recently. I've also been paid in the past by companies like Strawman, Shofu, Clear, Solution Reach, Air Techniques, Carry-Free, Philips, Ivoclar, Triadent, SDI, Voco, GlaxoSmithKline, Mars Wrigley, and Church and Dwight. I have faculty appointments at 2 dental schools. I had research funding from a group which used to be called Oragenics. It's now Probiora. I'm a huge fan of oral probiotics. And in my current role, I'm the Chief Dental Officer of the Alliance Dental Center, which is owned and operated by the Massachusetts Public Employees Fund. And like many of you, I'm in full-time clinical practice, providing wet finger dentistry to my patients 4.5 days a week. And the pictures of my presentation should verify that for you, because you should be able to tell just by looking at the photos that this is what I'm doing in clinical practice. These photos were snapped with the help of my assistant, Megan, who's on the phone with me tonight. I want to say thank you very much, Megan. I tried to get a picture of Megan in the presentation so you could all see what the person looks like who has to endure Brian Novi every single day. But so Megan, you're on the line. Thank you very much. And I expect that you will chime in to the Q&A or the chat or whatever is activated on your end so that you can tell everyone if this is exactly what we do in practice, because I think it is. I'm pretty sure it is, at least in my mind it is. So just so you know, all the pictures of my presentation are my own. I haven't photoshopped anything because I spent a bunch of money on a program which wouldn't allow me to actually, which I couldn't figure out how to use it. So I haven't photoshopped anything, but I may have adjusted some of my photos for contrast, brightness, gamma, or I may have cropped them. So there's my disclosure. And I hate to tell you that there's going to be a test at the end of this. If you're watching this remote and you're not doing it live with us tonight, there's going to be a learning assessment. But don't you worry, I'm going to help you get through it. Even though Viva Learning wanted me to create multiple choice questions, you will not like the multiple choice questions. So I didn't do that. I instead gave you 5 true and false questions. And if you see a yellow star on any one of these screens, that yellow star indicates that is probably going to show up on a quiz. But I'm going to try to drive home those points. I have the quiz right in front of you right now as I give the presentation. And hopefully I should get you very well prepared to score 100% on your test at the end of this lecture. So I want to give you kind of a lens for what my office looks like. This is my buddy in practice. This is Dr. Larry Faggio. I get to practice with him 2 days a week. And that's not the best picture of Larry. Here's a better picture of Larry. And this is what he has to put up with most days when he's in the office, or my shenanigans. On days when Dr. Larry's in the office, Dr. Sam joins me in the practice. And Dr. Sam was the interim program chair at Harvard School of Public Health, or Harvard Dental School in the Masters of Public Health program. And she helps us bring a public health lens to everything that we do in our office. And so the 3 of us share patients and share successes and also those not so successful moments in practice that allow us to learn from what we're doing and get better and better and better at it. And this is one of my patients. This is Janet. And for those of you who know me or have heard me speak in the last 2 years or so, I published a paper, a case study on how we took care of Janet. And tonight I'm going to walk you through some of those clinical procedures which actually led to Janet's outcome. And I'm planning to publish or at least try to publish a follow-up paper to show what Janet's looks like at 5 years, because not everything worked as splendidly as I thought it would. We've had just a few failures along the way, but so far everything is holding up pretty darn well, with just some touch-up little repairs here and there. Nothing as major as I would have expected. So I want to walk you through what I did with Janet, but how did Janet wind up in this case or in this situation where she's got recurrent decay on every single tooth or on every single restoration, except for that implant on tooth number 29? Every single tooth in her head is developing decay. And I find that the task of trying to rebuild a patient's mouth like Janet, you're trying to build Barbie's dream house in the middle of a forest fire. And that's the way our patient advocate describes it in our office. But this happens because Janet suffers from what I call medication-induced xerostomia, or mixed disease. And you can see all these dry mouth inducing medications that she's on. And if you look really closely at the top of your screen, these are the additional medications which don't show up elsewhere on her health history. So one can only imagine how dry her mouth must be. But we're also dealing with a lot of other issues like lupus popping up in the mouth and a lot of soft tissue irritation. And so We have tried lots of different things on Janet. I feel like we finally have gotten we've gotten to be in a situation where we're quite predictable, and Janet's coming in just for her 3 to 4 month recare right now, and we've, like I said, we've touched up some restorations, but I'm still battling all these medications, and I can't change these medications because if we change these medications, Janet's going to fail to thrive on this planet. So I'm battling medication-induced xerostomia, and I set about a plan where I tried to restore every single tooth in her mouth step by step. I started off early on thinking I'm going to do quadrant dentistry. And of course, Megan can tell you very rarely do I do quadrant dentistry because I tend to get in over my head and go, whoa, I guess we're going to only do one tooth today. But I started like here on this canine, and what I did is I removed all the failing composite, and then I rebuilt the tooth with glass ionomer. I like to restore every tooth with conventional glass ionomer. If I can't restore a tooth with glass ionomer, I like to restore a tooth with resin modified glass ionomer. If I can't do that, well, then since I was taught at Loma Linda University School of Dentistry, my fallback, my third option is to lay hands on you and pray. But I find that I don't need to do that when I use glass ionomer. So I do a large glass ionomer buildup on these teeth, and then I come back later, and then I prep them for some sort of indirect restoration on the teeth where I think they need it. So we prevent a catastrophic failure. But before I do any of this, what I really want to do is I want to understand the physiology of Janet's mouth so I can get to the root cause of her disease and try to balance those risk factors in her mouth so she stops developing disease. When you're sitting there or wherever you are in your practice right now, typing your treatment notes, or if you're at home cooking dinner for your family, or maybe you're eating dinner all alone, wherever you are, I imagine you're looking at the screen going, wait a second, what is that device on the countertop right there? This is actually our saliva analysis platform. This is not a lecture on saliva, so I don't want to spend a whole lot of time talking about saliva, but if you want to ask me a question, go ahead and put it in the Q&A, and I'll maybe the folks at Viva Learning will, this will whet their appetite to do a webinar on saliva or on salivary testing, because that's not our point. That's not what we want to do here tonight. What I want to do is get to some clinical protocols that you can actually use with restorative materials that lead to a decreased caries risk for your patients. And showing you this saliva testing device got way ahead of ourselves. We're now off topic on saliva. I'm going to get us back on topic here. But before we do that, I just want to tell you there is a handout for tonight's presentation. So the handout for tonight's presentation is a document that you should be able to find pretty easily online. It's going to be the evidence-based clinical practice guideline on non-restorative treatments for caries lesions from the American Dental Association, which is based on the systematic review and network meta-analysis on non-restorative treatment for caries, which was published in the Journal of Dental Research. I just want to point out that when this paper was published in the Journal of Dental Research in 2019, it won the Guy's Award as the most influential paper in the dental literature on the planet Earth. And the American Dental Association took this document, the same group of people who worked, almost the same group of people who worked in systematic review for the Journal of Dental Research, then sat down at the American Dental Association and created these clinical practice guidelines, which really gave us a rubric for what we can do to treat caries that doesn't involve a drill. And when the pandemic hit, I just thought it was amazing that we had a clinical practice guideline that we could point to and say, since we can't operate a drill and create aerosols, what could we do? What remineralization agents have the most evidence behind them? And how can we deploy those? That was all part of this clinical practice guideline that the ADA put out. If you really want another handout, you want some more meaty handouts, you could go to my website, www.holymolar.com or www.holymolar.net. That's going to take you to this website. And when you get to this website, I've got a whole bunch of handouts on here. And I'm not going to go through all these handouts because you can click through them on your own. But if you are looking for a protocol for dry mouth, let me just say Matt's protocol at the end there is my dry mouth protocol. There are 2 mouthwashes that are mentioned in that dry mouth protocol, which are no longer available. It's a shame that that company didn't make it through the pandemic. But Synodent and Moisten, sadly, are no longer with us as therapeutics that we can use for our dry mouth patients. My new go-to for dry mouth, and Megan can attest to this, I just talked to a patient about it today. I have 1 bottle of the spray in my office. It's called Saliva, Salivea. It's my go-to now for dry mouth. Because it's the one thing that has enzymes in it, which will actually replace the missing enzymes in the saliva. But I have a lot of other things that go into my dry mouth protocol. They're all in Matt's protocol, and you can read it right there if you'd like. So I don't want to tell you about what I personally do in practice, though. I really want to base tonight's lecture on systematic reviews and on the highest levels of evidence. And really, what I'm going to be doing is just sharing my personal opinion, which in my personal opinion is based on the highest levels of evidence that I see in the systematic reviews and those randomized controlled trials that get picked up in this process of actually having groups of experts review all these randomized controlled trials and then come up with a systematic review, which summarizes all of them, tries to combine all the data into one gigantic pile of data that can be analyzed. And hopefully you can extrapolate what that meta-analysis or that systematic review has in it. You can extrapolate that and apply it to clinical practice. Now, the same results that you see in the systematic, that are reported in the systematic review. Systematic reviews, they're very simple processes, just like this diagram illustrates. They're not very complicated at all. Actually, they're very complicated. It takes a long time, a lot of people's efforts, a lot of reading, a lot of data analysis, a lot of leg wrestling to figure out whose research we're going to put in the systematic review, and how are we going to judge the quality of the evidence, and how we're going to judge the bias. And that gets us to a final systematic review. And I'm going to talk about some of those systematic reviews which inform my decisions to use glass ionomer with, I'm going to say, vigor, and actually use materials in a way that leads to less recurrent decay. And I'm going to back that up with some of the systematic reviews in the literature that's out there. This is what it looks like when a systematic review happens. This is the room where the clinical practice guidelines were written based on the systematic review. The meeting room is just about as engaging as you think it would be. There's a lot of paper on the tables and a lot of very smart people in the room who for some reason include me at that table. And I get to sit there and chat with all these folks and talk about my experience in clinical practice. And again, like I said, it was based on this systematic review and then in the Journal of Dental Research. But backing up just a step, there's a wonderful guy out there, researcher who runs a PhD program in oral biology called Bob Burney. And he says in his paper, Oral Streptococci Products of Their Environment, he says that agents designed to produce a more favorable ecologic balance may ultimately be the most effective in controlling caries. And when I first read this paper, I thought that what Bob was talking about was therapeutics that create a balance, an ecologic balance. And I, in retrospect, I don't think he meant that. I think what Bob Burney meant, and maybe if he didn't mean this, I'm gonna grow what he wrote. And I think what he's trying to say is that when we clinicians are trained and designed by our training to change the ecology of the human mouth, we will be the most effective clinicians at controlling dental caries. If we bring our knowledge of the fact that the mouth is a very unique environment, unique to every single patient, with unique chemistry and physiology, and carries risk factors and protective factors, and social determinants of health, and maybe in a family situation, maybe contributing to disease or helping their disease. When we take that into account, we bring to the table a much better ability to effectively control caries in our patients' mouths. And so I just want to say thank you for giving up your Wednesday night tonight after probably a busy day to come and just listen to some guy talk about how he treats caries with his restorative materials, because I do think that the way we restore teeth has a lot to do with how often we have to battle recurrent decay. And when I think of the word balance, like Bob used in his paper, I immediately think of Canberra, because Canberra's got that balance in there. If you don't already know about me, I am currently the president of the National Canberra Coalition. I'm in my second year as the president. And Canberra's been undergoing a dramatic change to really create a 10-year plan where we show a demonstrable improvement in caries rates in certain practices across the country. So if any of you want to get involved in Canberra, want to know more about what we're doing, just look up canberracoalition.org, and we're going to be having a real live in-person meeting according to our plan in 2023. And in Canberra, we talked about this caries balance, that the pH of the mouth is a very critical factor, and that pH of the mouth, as it fluctuates and as the mouth becomes acidic, you start to develop dental disease, or maybe not even dental disease. Maybe you go past dental disease to acid erosion or candidiasis. That's if your mouth gets really acidic, you develop that sort of thing. But if your mouth is mildly acidic in the pH range of 6.6 to 5.5, you're going to have this slow demineralization process that occurs. But if the pH of your mouth is above 6.8, you're actually going to lead to remineralization. Of course, when I start talking about the pH of the mouth, you have to ask yourself the question, well, what are you talking about when you say the pH of the mouth, Brian? What are you talking about? Are you talking about the pH of the stimulated saliva? Are you talking about the pH of the resting saliva? Are you talking about the pH of the saliva coming from the minor salivary glands, which dot the mucosa? Are you talking about the pH of the plaque fluid? Are you talking about the pH under the tongue? You're talking about the pH in the buccal vestibules? You're talking about the pH in the maxillary anterior? There are many different environments in the mouth. And so you can't just say the pH of the mouth is this. be a little bit more specific when you say pH. Yes, this is a pH dictated disease, but it's the pH at the local tooth surface that's causing the problem. And then you have a pH elsewhere in the mouth, which may be able to neutralize that if you've got really good quality saliva. And we can spend an entire hour, actually well more than an hour, on this little teeter-totter. I don't want to. I just want to point out, I think something's missing here in those protective factors over there. And when you say fluoride, calcium, and phosphate are protective factors, I hope what you take away from tonight's presentation is that strontium is a really key protective factor. And this is not new. We just don't talk about it a whole lot. But when you have a dental material that has strontium in it, we have known for a very long time, based on research from the United States Navy, that when strontium is added to drinking water, teeth become very, very strong. They do not develop that modeling that you get with fluorosis. And when you have restorative materials with strontium based filler in them, that strontium has the ability to leave the restorative material, go into the tooth, and really strengthen the tooth and create what I'm going to call quote unquote strontium apatite, which is like this wicked strong tooth crystal, which seems to be very, very caries resistant. So I tend to pick up glass ionomers, which are strontium based. GC America's glass ionomers are strontium based. That's one of the reasons why I like their glass ionomers so much. And of course, I assume some of you have listened to my Viva Learning webinars before. Last time I was with you, I talked about GC's new sealant material, GC Fuji 7 EP. I think the EP stands for extra protection because it's got recaldent in it. And when before this was released, I got a box in our office, and Megan and I started using it on some patients. And I want to point out, GC was really creative when they created this product. We've got the systematic review in the Journal of Dental Research. I'm going to zoom in on some of these network meta-analyses that are here. And if you look at your screen, I'm going to circle some things here. Here we know sealants work really well to treat caries. We also know that CPP, ACP works well to treat caries. Look at the strength of these lines. Now, we only have one study really, but we have 1,443 lesions that in a systematic review have been successfully treated with 10% CPP, ACP. We also in that systematic review of 201 lesions were successfully treated with sealants, giving us a really high level of evidence that sealants are great at preventing tooth decay. We also know CPP, ACP does. Well, the question in my mind becomes, well, what if you combine these two things? If you look at this systematic review, you'll notice there's really not a whole lot of combination therapy in the systematic review. But I got to hand it to the folks at the R&D department at GC. And it wasn't just because of the systematic review. This product was in the works for a little while. When you start combining these therapies together, you really start to see dramatic improvements in oral health. You can't just focus on one anti-caries modality, like, I don't know, maybe everyone's favorite electronegative anion. I don't think you can just focus on getting that one thing in the patient's mouth all the time, because we can't fluoridate our way out of this disease. We've got to hit this disease from multiple different angles, because this is a multifactorial disease. So I could dwell on this. I'm not going to dwell on this. I love the fact that GC is thinking very creatively, trying to combine the technologies that we know work to see, can we get even better than we're already doing? And of course, if you know me, you know that I love glass ionomer. I love glass ionomer because differently than you see with amalgam restorations, you see in amalgam restorations, you see this margin where the amalgam doesn't quite meet the side of the tooth. And let me just back up for a second and say these images are taken with a scan electron microscope in our lab at Loma Linda University. Actually, a sand electron microscope that we contracted to use as part of a student research project looking at restoration margins in vivo, actually restoration margins in situ, where we took very highly accurate impressions of restorations, looked at those impressions under the scan electron microscope, and this is what we saw. What we saw was that an amalgam has a gap between the amalgam and the tooth, which is so deep you can't see what's at the bottom of that gap. Composite, same thing. We got a nice, beautiful gap there. But when you start looking at glass ionomer restorations, you don't see a gap form between the glass ionomer and the tooth, even after the glass ionomer has been in the mouth for a very long time. Let me qualify, very long time, a couple of years. You still don't see a gap forming between the glass ionomer and the tooth. And that's because there's a hermetic seal that forms between glass ionomer and tooth structure. And I just want to point out here, I happened to listen to a lecture a couple months ago by someone I'm going to call everyone's favorite dental guru. And everyone's favorite dental guru quoted some quote unquote research coming out of another work group where this group said, yeah, glass ionomer is great. Today's glass ionomers are amazing, and you should combine them with other things like Gluma. And when I heard that, I screamed. I screamed out loud in my living room going, how could you say that? That's not based on any fact. That's not based on what the R&D department of GC says. That actually goes against what the instructions for you say. And how long do we know? And what's the longevity of those restorations you put gluma underneath it? So before I go any further, let me just say, if you're going to place glass ionomer in a tooth, please don't put anything in between your glass ionomer and your tooth. Get that tooth really, really clean with the cavity conditioner that GC supplies. It's a polyacrylic acid, very weak cleansing agent. In fact, Megan can attest, I clean just about everything in the office with not everything inside the mouth with polyacrylic acid before I do anything. It's just the way I get things clean. I prefer to not use phosphoric acid. Actually, like a gentler cleansing agent, and I use cavity conditioner for that. And I would never put anything between the glass ionomer and the tooth. And just today I said to Megan, if you ever wind up working with any other dentist and they ask you, how did Brian get his Fuji 2 restorations to look so good? Make sure you tell them you gotta put it on a dry tooth, get it to stick, coat it really well with that coating agent that they supply you with, and impregnate that into the surface as the material is setting. And then light cure it, and hopefully you don't have to go back in and do anything to it. You will wind up with a beautifully translucent result. Your class 5 Fuji 2 restorations should look better than any composite class 5. And you should have margins which are going to be hermetically sealed. And even our systematic reviews in the Journal of Dental Materials tell us that class 5 abfraction, I know I just lost half the audience by saying abfraction, class 5 restorations restored with resin modified glass ionomer have the best chance of success. And by their definition of success, that restoration stays in the tooth. It doesn't just pop out. So the other great thing about glass ionomer was that I was taught by some dental students who were doing research with me, and I just want to thank Danny and Elijah for teaching me this, that when you take glass ionomer specifically and you put fluoride on glass ionomer, fluoride can actually move through the glass ionomer in less than 24 hours and come out on the other side of that glass ionomer. But it's not going to do that with composite because composite does not release anything. Composite doesn't suck up or imbibe anything either. And in fact, if you put a layer of bonding agent anywhere in that glass ionomer, and I'm just going to say, maybe like gluma on the intaglio prep, which has HEMA and glutaraldehyde. So those are two, I'm going to call them contaminants to that surface. When you put that in there, you actually inhibit fluoride from actually moving through that layer, because anything with resin is going to be hydrophobic, and fluoride has to move with water. Meaning if you're using anything that's hydrophobic, I know some of you use hydrophilic sealant materials, and let me just ask, are you worried about water in the mouth, or are you worried about saliva in the mouth? Because when we talk about materials being hydrophobic or hydrophilic, immediately I think, why does it even matter? The mouth has saliva in it. That's a proteinaceous fluid. That's not water. Yes, it's made up of 99% water, but it's not water. So if you're using a material that's quote unquote hydrophilic, that means it's attracted to water, but there's no water in the mouth. There's saliva in the mouth. So if you're talking about, well, this works because on a saliva coated tooth because it's hydrophilic. No. Saliva's not water. Yes, it has water in it, but there's a lot of protein in it, and that protein changes the hydrophilicity, hydrophobicity of saliva. And you know this because you know saliva is a great surfactant. So all that to say, please just remember that if you're thinking about fluoride moving anywhere, it has to move through something that is not repelling water, because fluoride moves with water. Glass ionomer is a water-based material, so there's always a little bit of water in the glass ionomer. That's why the fluoride can just move right through the glass ionomer and come out the other side. And by the other side, I mean, if you have a glass ionomer restoration or sealant in the patient's mouth, you put fluoride on that, it imbibes the fluoride and it slowly releases it over time. And we see this we've demonstrated this in research for over, it seems like it's been at least 20 years, because I remember learning about that in dental school. And I would imagine back in the 80s, they had originally identified that this was happening. So that's great that I've quoted some students doing some research and showed you some wonderful cartoons that I made in a PowerPoint slide to show fluoride moving through different cylinders of material. But the reality is, like I said in the beginning, I want to back up my lecture with the highest levels of evidence. So why don't we look at a systematic review from the Journal of the American Dental Association, published on my birthday in 2016. And that systematic review actually was looking at something very differently than any other systematic review looked for in sealants. This defined a successful sealant as one in which the tooth does not develop a cavity. So think about this. Prior systematic reviews and sealant research has looked at the outcome of a successful sealant as a sealant that stayed in the tooth. And as long as the sealant stayed in the tooth, we thought that it was working. Well, I don't know about you, but I see sealants that stay in a tooth. And when I press down with an explorer or a sickle scaler, I see it go, and you see smutch or schmutz squeeze out from around the edge. And if you flick that sealant off, you find a chewy nougat center underneath that sealant. So that, in my opinion, is not a successful sealant. In my opinion, a successful sealant is if the tooth fails to develop a cavity, not that the sealant is still visible to the naked human eye. And this becomes an issue when it comes to glass ionomer sealants, because we do see them over time in a really high-risk environment. Those sealants tend to, and I'm not going to say wear away because they don't wear away. Those sealants don't wear away. They sacrifice themselves. And as they sacrifice themselves, they release ions into the environment, which neutralizes that acidic environment, stops the degradation of the tooth. So in this systematic review in 2016, the ADA did something truly amazing. And what they did was they defined a successful sealant as one where the tooth did not develop a caries lesion, but they also looked at something else. This group of authors looked, or reviewers who became authors, this group of individuals looked at the success of placing glass ionomer over caries lesions to determine if it could arrest caries lesions. And let me just say, that is in fact what the systematic review actually says in the text, and what it demonstrates is that sealing teeth with glass ionomer has the potential to arrest caries lesions. So we know when you put glass ionomer on a virgin tooth, it protects the tooth really well. When you put glass ionomer on top of the caries lesion, it has the ability to inhibit that caries lesion and arrest it. And I'm not saying put glass ionomer on top of caries lesions, although I will show you a case where I have done that. But the systematic reviews do validate the fact that we see, and research has demonstrated that when you put glass ionomer on top of the caries lesion, it can arrest that caries lesion. Now, if you look at table 7 in that systematic review, this was the table that actually looking at resin-based sealants on one side of the mouth and composite-based resin-based sealants on one side of the mouth and glass ionomer on the other side of the mouth. So think split mouth design. You're going to seal all the molars in a kid's mouth. So let's say you're going to seal everything on the right side of the mouth with composite and everything on the left side of the mouth with glass ionomer. And then you're going to watch them for 2 to 3 years and see which teeth developed caries lesions, not which tooth had a sealant fall out, which tooth developed caries lesions. And you can see that up here at the top, there were some researchers, Chen and colleagues in 2012 did a study where they did 1,282 glass ionomer sealants, 452 resin composite sealants with a very narrow confidence interval. And what they found was that the resin composite sealants tended to do better at preventing caries lesions. That was when teeth were either carious or had deep fissures. When you look at teeth that don't have caries and you put glass ionomer on them, you can see Arrow and Reardon in 1995 did a study with 412 glass ionomer sealants, 412 composite sealants, narrow confidence interval. The glass ionomer sealants prevented caries lesions better. And you can see how each one of these studies stacks up. When you get down to the bottom, you can take all the data, aggregate it together. You get a total of 2,727 glass ionomer sealants, 2,014 composite sealants. But yet, still, when you look over here, if you meta-analyze the data tends to show you that the glass ionomer sealants, when teeth have glass ionomer sealants, they don't develop caries lesions like the teeth that are sealed with composite resin. Now, I know some of you are like, what? Hold on, back the truck up. Let's critically review one of these papers, because there's a paper in here written by Antonsen and colleagues in 2012, and they have a very wide confidence interval here. Now, I just happened to run into Dr. Sibel Antonsen at a conference, and Michelle, thank you for inviting me to a conference where Sibel was, because I sat next to Sibel on a bus, and I was like, "Oh my gosh, you're Dr. Antonsen! I talk about your sealant systematic review your sealant study all the time." And she said, "What do you say about my sealant systematic review?" And I said, "Well, you have that wide confidence interval and everything." So I followed her and I stalked her, and I followed her to her archery lesson. And here's a picture of Dr. Sibel Antonsen firing a bow and arrow. And I could not help but think, oh my gosh, it's almost like this forest plot. She's going to create a forest plot with her bow and arrow here as she shoots this bow and arrow. And she's going to create this same little confidence interval that she has here when she pulls back on that bow and arrow. She didn't quite do it. I don't know if this actually resonates with you, but here's her paper. She actually published her paper in JADA, February of 2012. And now, remember that confidence interval, very wide confidence interval. More of the glass ionomer did better. Some of the composite did okay. But look at what she says. In our study, caries developed in 2 patients in the resin-based sealant group, and the caries was present in the teeth in which the sealant was lost. This may have been due to different caries activities participants. However, we found no caries in teeth that had in the glass ionomer group, which is probably related to the material's high fluoride release or to the glass ionomer's particles remaining in the bottom of the fissures, because Barja, Fidalgo, and colleagues reported a similar result in their clinical study in which they compared a high viscosity glass ionomer with a resin-based sealant. And even Franken and Wolke reported that remnants of high viscosity glass ionomer materials are retained and block the deeper parts of the pitch and fissures even after the sealant appears to have disappeared clinically. So for those of you who are in practice and you put a glass ionomer sealant in a patient's mouth and they come back, you're like, it's gone. That sealant failed. No, the sealant didn't fail. Just because you can't see it doesn't mean that if you took an impression of that tooth and subjected it to scan electron microscopy, you would see that there is still a little remnant of glass ionomer at the base of that sealant, which is still working very, very hard. And that little remnant of sealant, which on the very bottom of that pit and fissure, is going to do more to protect pit and fissure caries than not having a sealant there at all, because it's down there right exactly where it needs to do its work. And plus, when you realize it's going to pick up fluoride and release fluoride into that tooth structure surrounding it, you can start to see why we see the caries protective effect of glass ionomer being superior to composite resin. So back to the forest plot. Notice again. Oh, look, there's a star. It's a horrible star that I'm drawing there. There's a star. I'm pretty sure what I wanted you to remember here is that it seems like glass ionomer seems to protect the tooth better from caries. And according, if you look at some of these papers, it's because of the fluoride release. I also think it's because of the hermetic sealing properties. Now, this is looking at 2 to 3 years. Do you care about that? No, you really don't care about that. I want my patients I want my patients' teeth to last longer than that. So if you go out 4 to 7 years, same thing. Actually, the evidence gets better. And we see that if you want caries to be reduced for 4 to 7 years, this forest plot clearly indicates that glass ionomer should be your material of choice, because the glass ionomer performed better in both of the studies in the systematic review than any of the composite resin. Their confidence intervals were smaller, and a much larger percentage of your glass ionomer resisted decay than the composite resin. So much so that when you do a meta-analysis of the data, that diamond is so far to the left of the line, you can see that the systematic review clearly favors the glass ionomer material. Now, I know there are people out there who go, yeah, but I still don't like the fact that it goes away. Don't worry about it. Don't worry that you're not seeing it. It's not going away. It's doing exactly what you wanted it to do. This is an SEM of a glass ionomer sealant that I put in a patient's tooth. And you can see, I do a fissurotomy. You can see where my diamond burr actually cut through the surface of the enamel and left scuff marks there. But even after this sealant was in a high-risk kiddo's mouth for a couple of years and the sealant material gradually wore away, the margin did not open up. We don't get demineralization on the edge of it. If we had gotten demineralization on the edge of it, we wouldn't see these burr cut marks. This enamel is still intact, solid enamel. It has not been degraded by some acid demineralization, because that glass ionomer is sacrificing itself as that little kiddo drinks Gatorade, or heaven forbid they drink Monster Energy drink or Red Bull. As they go into these horrible acidic challenges, that glass ionomer just releases a little bit of its calcium and its phosphate and its strontium and its fluoride, and it neutralizes that acidic environment right at the tooth surface so that the tooth doesn't decay, because that critical pH of the glass ionomer is about 5.6 and the critical pH of the tooth is 5.5, which means that that glass ionomer is so smart. Right as the pH starts approaching 5.5 where the tooth is going to demineralize, the glass ionomer just goes poof, releases a little bit of calcium, phosphate, fluoride, and strontium, neutralizes that plaque acid, and doesn't allow the enamel to reach its critical pH. Composite don't do that. Excuse me. Composite doesn't do that. Do not tell my English teacher mother that I just said composite don't do that. But composite don't do that, folks. Composite does not dissolve. It never will dissolve. And I think that's a problem. That's why I don't want composite resin as my sealant material, because if it's not going to dissolve away, that means the tooth is going to dissolve away and we're left with a sealant which is stuck to the tooth with caries underneath it. And that's what I see in practice from other composite resin sealants that are done outside my office. When they come into my office and I can flick those sealants off, what I often find is that nougat center under the tooth. So I ask you, when you start thinking about composite from this perspective, is this really what you want, is a bunch of solid composite in the pits and fissures of the teeth with demineralized teeth all around them? Or are you really trying to protect the tooth? This is a tooth that Megan and I saw last week. Clearly, that composite is not doing anything to stop caries. In fact, I don't know, Megan, if you remember, but I was snapping pictures along the way. And then when I got to this, I was like, I'm going to snap a picture right now because I'm going to get so deep into this. I'm not going to have time to keep snapping pictures. And ain't nobody got no time to keep snapping pictures like this unless you're Dr. Larry and you can snap 100 pictures in 5 minutes of every single thing you're doing. I don't know how he does it. I don't. I just stopped snapping pictures because you can all see the recurrent decay under this composite, which was not going anywhere. It was still really stuck in that tooth. This tooth was symptomatic, and I wound up doing an inlay on it, or an onlay. Megan, you may want to put in the Q&A what we actually did, if you remember. I think we did an onlay, or I know we didn't do a crown. Now, that's great. I've quoted it. I've quoted a systematic review, one systematic review on sealants. Many of you are not doing sealants. You might be doing restorations. We have another systematic review from JADA, by the way, in 2016, where they looked at the rate of recurrent decay in glass ionomer restored teeth versus composite resin restored teeth. And when it came to occlusal restorations, it didn't seem to matter. But when it came to class 2 restorations, which I'm going to say are probably infinitely more caries prone or more prone to recurrent decay than an occlusal restoration, because most of us can brush our occlusal restorations pretty well. It's those interproximal lesions where patients don't floss that I think are more likely to decay. And it's those class 2 restorations where the glass ionomer is associated significantly with better ability to prevent recurrent caries lesions in pediatric primary molars in pediatric patients. So think about a pediatric patient with a class 2 restoration. When it's made out of glass ionomer, it gets less recurrent decay than if you make that class 2 restoration out of composite. Also, these glass ionomer restorations, don't forget, they're releasing ions into the tooth. And as long as you don't have any layer of composite in between that tooth and that glass ionomer, the glass ionomer can release those ions directly into the tooth, and those ions will move back and forth between the tooth. And he and Noah has shown in his research that what that creates is this chemical fusion zone between the glass ionomer and the tooth, which is literally the strongest part of your restoration. No longer do you have to worry about your margin being your weak link, because when you use glass ionomer, your margin becomes your strongest link. Now, you will see, I'm not going to tell you you're not going to see glass ionomers dissolve away in your highest caries risk patients. I say that's a great thing because that's exactly what I want it to do. If it didn't dissolve away, that patient would get recurrent. If I use composite and the composite wasn't dissolving away, I'd be dealing with recurrent decay in that patient's mouth. And I don't want to deal with recurrent decay in a patient's mouth. I would much rather see something like this. This entire quadrant has been restored with glass ionomer. You can see there's a class 2 here. And in this class 2, this patient doesn't floss. He was leaving plaque right here, and that plaque broke down the side of my glass ionomer restoration here. It didn't do anything to the molar, probably because that's such a large bulk of glass ionomer. The premolar was a smaller piece of glass ionomer. It could easily be dissolved away, or more easily be dissolved away than that larger surface of the mesial of the molar. But why is this happening? Don't let this stop you from using the material. Instead, ask yourself, why did this happen? Why did it happen? Because this patient has the most acidic plaque of any patient I know. Those of you who've heard me lecture, I can tell you a lot about this patient, Aaron. He can't put anything in his mouth. He can't put a toothbrush in his mouth. He can't put a spoon in his mouth. He can't put a fork in his mouth. He can't put his fingers in his mouth to floss his teeth. So it's no wonder that when he stained the plaque on his teeth with triplaque ID gel, which tells us the pH of the plaque, if the plaque turns blue with this disclosing agent, it means that it's going to destroy fluorapatite. Even if the tooth has fluoride around, the pH of this plaque is below 4.5, and it's going to destroy any tooth which has been ensconced in fluoride even. You're not going to be able to stop it when the plaque is blue. Blue plaque is below the critical pH of fluorapatite, not just the critical pH of hydroxyapatite, the critical pH of fluorapatite, which means fluoride isn't going to stop this blue plaque. So this patient is developing this caries lesion in his premolar because he doesn't floss. He's got acidic plaque sitting between his teeth. He just can't clean it. So what do? I simply just cut a little slot prep right in the top there, put in a sectional matrix, do a little cavity conditioner, rinse it out, dry it slightly, leaving it a little bit moist, and I squirt in some more glass ionomer, and he's good for another 3,000 miles. Those of you who might be thinking about sandwich restorations, if you're doing sandwich restorations, please remember the sandwich, the bread is the tooth and composite. That's your bread. The meat of your sandwich is your glass ionomer. So inside your sandwich goes your glass ionomer. The composite is one piece of bread. The tooth is the other piece of bread. These reverse sandwich restorations were done by a dentist who heard me talk about sandwich restorations, went back to the office to try sandwich restoration, sent me this radiograph of the sandwich restorations going horribly wrong, and said, Dr. Novi, what happened? These sandwich restorations. I was like, what kind of sandwiches are those? And she said, it did exactly the way you told us. And I said, no, you didn't. And this dentist got the bread and the meat mixed up. And this dentist put the composite on the inside and put glass ionomer on the outside. And that allowed the glass ionomer to selectively be dissolved away by the acidic plaque, which wasn't being flossed out, but it left composite bases. And now we have nice plaque traps around composites with composite bases. So if you're going to do sandwich restorations, remember, you're basically doing a base out of glass ionomer and then covering that base of glass ionomer with composite. Now, here's a clinical example. So for those, this is what you came for, because what I really want to show you tonight, what I want to spend the rest of our time together with, is I want to spend our time showing you my clinical technique, because this is what people ask me about. This is what people ask me about all the time, is how do you do this in practice? So this is a molar that came in. This is not the ideal case to show you, but this is the ideal case for me to photograph, because it could actually see, you can see really well what I'm doing here. So obviously the tooth came in, it's missing the, the lingual half of it. It's got a large amalgam restoration in there. What I have started doing is I do a lot of CEREC restorations in my office using CERESmart 270 as my material of choice, just because it's so easy. You don't have to fire it. It polishes absolutely gorgeously with very little effort. It mills out in between 7 and 10 minutes, and then with a quick polish, with what I call a whisker wheel, a little polishing cup, I get a wonderful polish on it. But before I place it on the tooth, I do a marginal elevation with glass ionomer. Then I do a hybrid immediate dentinal sealing technique, and then I cement I bond in my CEREC restoration. So what I'm left with at the end of my technique is I have a glass ionomer collar around the tooth, and that's key. If you look at what I did here, notice I didn't do a whole glass ionomer base building up the middle of the tooth with the glass ionomer, and that's really significant. I'm going to show you another clinical case where I've learned through the years that I don't just want a glass ionomer base there, because if this patient is extremely high caries risk and that glass ionomer starts to sacrifice itself to save the tooth, the restoration will debond faster if there's a whole base of glass ionomer, as opposed to if you had like the occlusal table of the tooth left indented. So what I do is I place my glass ionomer collar in the tooth, I elevate my margins. So at the most plaque retentive site of the tooth, that's gonna be made out of glass ionomer. Then I use a bonding agent, a two-step bonding agent, which is in this case is G2 bond. I find that because it was made specifically for the IDS technique, it works beautifully for this. And I coat the whole thing in bonding agent. That bonding agent flows down over the sides of my glass ionomer collar, which is exactly what I want, because it's going to make them even more acid insoluble, give them a little bit more wear resistance to any acids which are going to be marinating the surface. But it's not going to, that coating agent is going to stay on there forever, because as I clean off my cement after bonding this on, I may scrape away some of that. So some of it's going to stay, some of it's going to go away as I remove my cement. But in the end, what you can see is this nice little layer of a glass ionomer collar. And then I have with the glass ionomer is made out of Equiforte. I do G2 bond, the primer, and then the adhesive over the top. I mill up my CERESmart crown, and then I cement that CERESmart crown with GSIM1, which is a traditional resin cement that GC has. I snapped this picture 4 months post-op. That restoration has now been in there 7 months. And I will, if you come to any of my in-person lectures, I'll continue to update you and show you what this looks like over time, because if you know me, I typically don't show any restorative techniques unless I've seen it last for a year, and I'm showing you things that haven't been in the mouth a year yet. But Megan, if you want to chat in the Q&A, if there's anything I'm misspeaking on that's going differently in our operatory, feel free to keep me honest. So, second, there we go. So this is another case, and I know Megan's going to remember this case very well. This patient came in, and you can see she had a little bit of a problem. We diagnosed recurrent decay around the crown. When I removed the crown, this is what I found underneath. Now I've already gone in. I removed a little bit of the soft, mushy, infected dentin from this tooth with a slow-speed rounder already. So we're getting there. We're beginning to get the caries out of this tooth, but I got to a point where it's like I'm getting real close to the cherry cordial center. And once I got everything out, I still didn't have a pulp exposure, believe it or not. And so we wound up doing a buildup out of glass ionomer. Now, mind you, I do want to say there's a picture here that I'm not showing you, which is this did not happen the same day. So I got so in over my head, as Megan will attest, is I was at a point where I was saying, we really need to think about extracting this tooth. This is not going to last very long. But I love being a hero dentist, so let's try this. And so what I did was I did a monolithic glass ionomer restoration and kind of contoured it, gave her a gross contour, sent her home, and she came back. And I prepped my monolithic glass ionomer buildup into this. And you can see I left that little occlusal table of enamel. I did a larger buildup of glass ionomer. I don't know that I would do such a large glass ionomer buildup. I think I might remove, now in retrospect, I might remove more of the, I might expose more of that enamel on the occlusal table just to get a better bond between my G2 bond and my Ceresmart crown and the cement we're using. Because again, that's where I get all my retention. Because if this glass ionomer sacrifices itself, I lose some of my retentive features of the crown. And so that crown will eventually debond. But as long as I leave, I've found as long as I leave, and my ratio that I tend to go for is at most 60% glass ionomer, 40% tooth structure. You can go to 50-50. You can even do less, but I would not make your buildup more than 60% glass ionomer. And if you're going to do it, you've got to coat your glass ionomer in a bonding agent. And I would recommend a two-step bonding agent for this, like G2 bond, because it's made specifically for the procedure of immediate dentinal sealing. Now, this is not dentinal sealing. This is glass ionomer sealing, sort of dentinal sealing. It's a hybrid technique. And I'm stealing a term from Pascal Monnier. If you read my article that the editor of Dental Economics reached out to me and asked me to write a paper about what I'm doing with my high caries patients. And I described this technique, and it was featured on the cover with Pascal Monnier, who created the immediate dental sealing technique. And I'm sure Pascal would say, this is not dental sealing, this is glass ionomer sealing. But it works really well to actually improve the longevity of my glass ionomer collars. And that's what I'm really excited about with this technique. And 9 months post-op, this is what the tooth looks like. Margins haven't opened. We have a beautiful caries-resistant collar on this tooth in the most plaque-retentive site. And we'll continue to monitor this tooth over time. It never did get a root canal. It still is in the lady's mouth. And hopefully I'll be able to show you a picture at about 12 months, and you'll be able to see that this tooth is still in function. So if you're gonna, as we talk more about caries, I'm not done with my clinical examples yet, but we're running out of time. I just want to say, as I start to talk about using these for smaller restorations in pediatric cases, if you're not using a caries classification system that allows you to track if the lesions are getting bigger or if they're regressing or remineralizing, please think about using some sort of caries classification system like the one that I created with the American Dental Association, where it actually allows you to grade lesions and say, this lesion has progressed or this lesion has not progressed. And of course, we have 50 shades of gray here, which tell us when we should stop sealing and start restoring these teeth. And I am one of those dentists who I do tend to seal moderate lesions. I know a lot of you would think, what? And I even think of myself nowadays. I'm like, if I had told myself back as a dental student, you're going to be putting glass ionomer on top of moderate lesions and arresting them, I would have said, what? No, you got to remove the decay. I'm in therapy learning how to clean teeth and get them squeaky clean. I disinfected every single prep in dental school with Conceptus scrub because I was certain that I needed to disinfect those preps. Had I just been using glass ionomer, I probably wouldn't have needed to do that. So I do seal my moderate lesions. I do tend to go more for the SMART. It's not the SMART technique. I go for SMART, which is silver modified atraumatic restorative technique for those kind of things. I'm going to show you one of those in a little bit. I'm going to show you one that actually turned into an advanced lesion as well. But if you really are looking for a roadmap on what you can do in practice, what the evidence says you should do, this is the global consensus document that was published that was supposed to provide a recipe for the planet Earth to treat tooth decay. And you can see that in a permanent tooth with a shallow to moderate lesion, which hasn't reached the inner quarter or the inner third to the inner quarter of dentin. So here's a radiograph which would show you a lesion that looks like that. If you have a lesion that looks like this radiographically, you have 4 options there on how to treat that lesion. You can certainly do what you were taught in school to do. You can drill down to mineral mother dentin and restore that tooth just like you normally would. You get paid for that. That's what insurance pays you to do. You can also perform atraumatic restorative technique, but don't do that in the United States because we don't do that. We call it ITR. I don't know why we have to call it something different. It's the same thing, but it's interim therapeutic restoration. We have a CBT code for that. That's your second option. You could perform non-restorative cavity control. Just try to remineralize that sucker. And you can do things like silver diamine fluoride. I'm going to show you a case where I did do that. Or if the tooth has not yet cavitated, you could seal it up. And I hope someone's listening to this, which is going to create a interproximal sealant material soon, because I would love to be able to create an interproximal glass ionomer sealant on a tooth and do something like I can do like a glass ionomer infiltration technique. I think that would be amazing. So according to our global consensus document, dentists should aim for lesion arrest and inactivation to preserve the dental hard tissues, avoid initiation of the restorative cycle, and retain the tooth for as long as possible with a strong evidence-based recommendation. That's for a permanent tooth. But if you look at a primary tooth, that statement still applies. But look what you can do with a deep lesion here, with a deep lesion in a primary molar, with a risk of pulp exposure, people, risk of pulp exposure. You can perform selective removal to soft, or you can perform a Hall technique. Now, I'm not a board certified pediatric dentist, but I do know a number of them. A Hall technique, and my understanding is, and someone correct me if I'm wrong, a Hall technique is where you take a crown form like a stainless steel crown. You do not anesthetize the tooth, just like you don't for the smart restoration. You don't anesthetize tooth when you do silver modified atraumatic restorative technique either, because you don't need to. But when you do a Hall technique, you take a stainless steel crown form or some crown form, you fill it with glass ionomer, and you just put it on the tooth. You don't drill the tooth, you don't remove any caries. You rely upon the amazing sealing and anti-caries activity of glass ionomer, ensconce that tooth in glass ionomer, and stop the caries attacking the tooth by just wrapping the whole tooth in glass ionomer and providing an impervious surface above that the child can chew on. I may have got the nuances of the Hall technique wrong. If I did, I apologize. Let me just say, Viva Learning and GC America and none of my sponsors anywhere are responsible for what comes out of my mouth here tonight. So please do not blame them if I say anything that's inaccurate. So this is a little kiddo that I treated a couple weeks ago. This is the son of a dentist. This little guy has received a lot of disease management. We're trying to keep his experience of the dentist really, really good. He has got an amazing ability to tilt his head back. So when I work on his maxillary teeth, it's like working on a mandibular tooth. I love it. This guy is awesome. So I asked for this picture to be snapped so that you can all see. This is what my patients do. And I say, can you tilt your head back for me? Although he tried really hard, and I just have to say, he did at one point. He goes, can I put my head down now? Because it's getting kind of sore. And I was like, yeah, you can put your head down now, but you're being a really good doctor's helper. And this is what he had. So we had actually treated his molar with silver diamine fluoride. We knew there was an interproximal lesion there. I don't use silver diamine fluoride the same way a lot of dentists do. I don't floss it into contacts. I dry off the contact really well. I put a drop of silver diamine fluoride in that contact, let it marinate for about a minute. I rinse it off, dry it really well, and do it again. That's what I prefer to do with my interproximal restorations. When it comes to, you can see this molar received a beautiful Fuji triage sealant. We got that beautiful pink sealant material there, so we can see that it's still there. We know it's still working. We know it's working because as long as it's there, it's going to release bursts of fluoride in the environment as the pH lowers. But look what happened to that mesial surface. It actually cavitated. Even though it had been treated with silver diamine fluoride, it still cavitated, which makes sense. And people, I think clinicians are kind of surprised when they see this. They think that it's not going to cavitate. It's still going to cavitate if the child bites down on something really, really hard, because you haven't put anything inside the tooth to build up the body of the lesion. All you simply did was arrest it, chemically cauterize the lesion, fill it up with silver phosphate. But the tooth, you didn't actually strengthen the tooth or reinforce the tooth. So sometimes they do cavitate, and it's not a failure. It did exact. And the beautiful thing about this is if you go with the slow speed round burr, it's hard. You can't actually get anything out of here except for food. So I pull all the food out and I floss it really well. I get it nice and clean. And you can see that even after flossing, he's not bleeding. He's doing a pretty good job of keeping it clean, but he had food packed in there. I get in there with a slow speed, like number 1 or number 2 round burr, and I gently just spin that around a little bit, see if anything is soft. Nothing is soft. So then I take a microbrush. I might put a little bit more silver diamine fluoride in there, or in this case, just some cavity conditioner, clean it out. I have a little, I forget what these things are called, these little wedges with a kind of a matrix on them at the same time. Slide that in there, squirt in some glass ionomer, let it set, pull out my little matrix, floss it. Sometimes I don't floss it. Sometimes I use sometimes I don't use that little matrix. Sometimes I use the tooth as a matrix. And as long as that glass ionomer doesn't set, I just take a piece of really fine floss, wax floss. You don't use cocoa floss for this. I'm a huge fan of cocoa floss, but I find that like a nice generic white floss is best for this because it doesn't shred really well and you don't get fibers in your glass ionomer. Just pass it through that contact and create your contour with some floss. And when I get done, the little kiddo wants to see exactly, show me the pictures, Dr. Brian, show me what you did. And so we stop and we talk about what we did. And I explained to him, this is, these pink little sealants, they're protecting the tooth where you chew, but in between the teeth, since you weren't flossing, you got this cavity. And so we fill that up for you. And I don't anesthetize when I do this because you don't need to anesthetize. The lesion is arrested, and I can do a little bit of light preparation without any anesthesia whatsoever. I do sometimes use some compounded Tricaine topical, and I'll put that in the contact before I slide the matrix in, just so the little kiddo doesn't feel the pressure of the matrix going in there. This is another case. This is usually how we use glass ionomer. At an initial appointment, when I identify a cavitated caries lesion, I explain to the parent, I can put a liquid on here that will stop the cavity from getting any bigger. And they're going to know it's working because the tooth is going to develop a freckle. Kiddo comes back. I check the cavitated advanced lesion. It's hard. I can't, if I take a spoon in there or a slow speed round burr, nothing moves. This thing is rock solid under there. And so I don't anesthetize. I don't do anything at all. I just put some cavity conditioner in there, rinse it off really well, leave the tooth slightly moist, inject my Equia Forte, and then I put my coating agent over the top of it and I light cure it. And you can see the beautiful thing about glass ionomer on top of silver diamond fluoride treated tooth structure is it's so opaque it masks that dark stain that we see from the silver phosphate as it cauterizes the caries lesion. And now we come to the end where I've told you about the restorative technique, but please don't forget that you got a lot of wonderful therapeutic agents out there, which are joining the chemistries that we see in that systematic review that I started with. Marrying these chemistries together is just going to continue to create a world where we have got amazing therapeutics that they all do amazing things to change the chemistry of the saliva, harden teeth, kill bacteria, nurture the growth of good bacteria, raise the pH of the mouth to non-chirurgenic remineralization levels, and even clean the teeth better. And things like MI Paste 1. Now that we have MI Paste, if you haven't tried Blue Raspberry MI Paste 1 for kids, it's now become my favorite flavor toothpaste. But we have these amazing products that we now can leave a little bit of plaque behind, knowing that there's something in there that's going to saturate that plaque with calcium and phosphate and fluoride. And so that plaque will become a remineralizing plaque, or if it's not going to become a remineralizing plaque, will not become a demineralizing plaque because we've given it all the ions it needs to become to not reach that critical pH. So as you think about how to keep your patients healthy, remember your restorations, that's one piece of the puzzle. But always stop and ask your patient, if I could give you one more thing that would help you have a healthier mouth, would it be easier for you to have a new toothpaste, a new kind of floss, a new toothbrush, a new mouthwash, a new lozenge, a new mint, a new gum? Or would you like some new chocolate taffy or some new caramels? We got lots of things that we can use that will make your mouth healthier. You just need to tell me what fits in your routine best. And that's the one that I'm going to pick because it's not all these therapeutics work somewhat. They work better when you use them in the manner in which they're intended. But if you start combining chemistries together, they work amazingly well. So in our limited time together, I'm going to leave you with a picture of this little kiddo. I think it's a privilege to treat another human being. And if you don't enjoy it while you're doing it, you weren't doing it correctly. So peace be with you. And thank you for letting me talk about glass ionomer and how you can stop a coccus with your preparation and your restorative techniques. And now we have, oh my gosh, the Q&A is filling up, Trung. So we need to go to the Q&A. So let's see. Oh my gosh, I've got an old student who came just for the candy. I used to throw out candy. Hey, Jason, good to see you. Isabel's asking, I find that glass ionomer fails in dry mouth cases, maybe because it gets desiccated and breaks off. Am I doing something wrong? Isabel, no, you're not. I would imagine that in those dry mouth cases, those are the patients who, if you coat those glass ionomer restorations, you're going to see that they last longer. Also, if you're noticing that they're failing fast, try waiting a little bit longer before you start contouring that glass ionomer. And as you contour it, always contour it under water spray once it's set so that you keep it hydrated. You want to keep glass ionomer really well hydrated. If you notice that it's starting to get cracks in it and becoming like chalky, it is fracturing violently. In fact, if Megan, I don't know if there's a way to unmute Megan, but Megan will tell you, I say this every single time, Megan, what is the cardinal sin in working with glass ionomer? And she would say, don't dry it out. She knows, don't get anywhere near me with suction while I'm contouring a glass ionomer. Keep your suction away from me or give me little bursts of water. Okay, so Mike's asking, do you think some of the new so-called bioactive resin restoratives that claim to form hydroxyapatite from sealing and filling marginal gaps are effective? My personal experience is they are effective if you use a bonding agent, and that bonding agent acts as a barrier to my remineralization. So I have seen them become beautiful little inlays that come out. I do need to correct myself because I showed you a box of a material which it wasn't US. So the Fuji Triage EP in the United States, it's Fuji 7 EP. It's not Fuji Triage, or it's Fuji Triage EP in the United States. I had a box of Fuji 7 EP. Which wasn't for the US. I'm sorry that I showed you a picture of that. What brand of glass ionomer can you use for a sealant? You can use Fuji 2LC. In fact, that was one of the sealant materials used in the systematic review. That was one of the more successful ones because you've got it's light curable. But I use my go-to sealant material is usually Equia Forte, although in a little pediatric patient, that's when I use Fuji Triage, and I like Fuji Triage in kids. I like the pink color, and I find that some patients even like Pretty Princess pink sealants. And Megan is reminding me that we did an onlay on that composite. Megan said this. Oh, thank you, Megan. You reminded me. I tell all my patients when I do my IDS technique on the tooth, I always tell Megan to give them the shellac spiel, because as the bonding agent, as the G2 bond goes all over the tooth and over the prep, it goes down onto the gingiva, which is great because it seals off that gingival margin. I don't have to worry about any moisture contamination ever until this thing is completely cemented and I remove the cord. But what that does is that layer bonding agent flows over the gingiva, which is exactly what I want. And I tell the patient, if you find anything that looks like clear nail polish coming out of your mouth, it's just stuff that was stuck to your gingiva. And Megan has this way to remove it with a micro brush. I scrape with a scaler and I create hamburger meat with gingiva. So I let Megan do it. And Megan says she remembers the restoration was gorgeous. Thank you, Megan. I appreciate those of you who are giving me props on my technique. I was really worried about showing it on a global webinar like this. Gordon is asking, on deep subgingival margins on crowns, can you keep the prep margin above the gingiva margin, not on the dentin? Let's see, on deep subgingival margins on crowns, can you keep the prep margin above the gingiva? I always try to keep my prep margin above the gingiva, and if I don't, that's when I do my marginal elevation with glass ionomer. So I'm always trying to create super gingival margins, and if I can't create a super gingival margin, that's where I want my glass ionomer down there. Mike wants to know if I have an opinion on DMG's Icon. Yes, I do. I have used Icon. I don't have the research and the systematic review show Icon is incredibly effective. It's a little expensive for my taste. You have to use a rubber dam with it. Patients do tend to say, I'd rather be anesthetized next time you do that. And the most successful patient I had actually moved to England, and I had a call from a dentist in England. She lost her little wallet card, which actually had me draw the description of how radiographic the lesion looked when I treated it. So the dentist who saw it next would know what it looked like. She didn't have her wallet card, so they just cut in and remove my Icon restoration. Megan wants me to tell you that the assistant that was shown chairside is not Megan. That was Kathy. Thank you very much, Megan. Jenny, do you have a bite wing? Do I have bite wing x-rays of the child's tooth? I don't in the presentation, I'm sorry to say, Jenny. I apologize about that. And Carol, please elaborate on Coccofloss. Am I hungry? No. Oh, Carol, Coccofloss. It's like the most amazing floss. It's like a flossing vacation. It's microfiber floss lubricated with coconut oil. It comes in an amazing array of flavors. And with that, oh my gosh, it's 8:02. We went 2 minutes over. I am so appreciative of you all giving up your Wednesday evening. Please enjoy the rest of your week. Stay safe out there. And hopefully I'll get invited back for another Viva Learning webinar. It's always a pleasure to be with you. And I hope I've given you just a few little things that you can take back to practice tomorrow. Have a great night.